All right, everyone. Well, I think we should get going again with our next speaker and our visiting professor. So first, I'm going to have we'll have a short introduction, and then we'll get going.
Thanks. It's really my great honor to introduce Dr. Lyndsay Harshman, who comes visiting us from the University of Iowa. She endured a 3-hour flight delay in Chicago to come see us, we're just so thankful that she's here. So not only is she an associate professor at the University of Iowa, she's an established investigator, physician scientist, and really pioneered, I think, this area of neurocognition and chronic kidney disease. I remember when this topic came up when Lyndsay was starting, and it's a tough topic, and then I hope in the course of her presentation you'll really appreciate the scientific rigor that she took to really make headways in this field, and really will be a trailblazer in this. So thanks.
Good morning. It is a pleasure to be here today. I have greatly enjoyed the visit thus far. Again, Chicago tried to thwart me, but I surpassed it. So we're going through Dallas on the way home. We'll see if that's good. But I'm going to take you on a bit of a whirlwind tour of the brain in CKD. Hopefully at the end of the talk, the appreciation for the mutual synergy of both cortices comes into play. And I hope too that this really directly complements what the talk we just heard as well. And I think it will. And I hope it's not too sobering, because I think you'll find that there are some very discrete things that we simply can't fix about how we take care of our pediatric patients, but recognition and awareness are critically important in how we support our patients. So with that, I do have some current support here that I'd like to recognize that was important for the success of this project. No financial disclosures. Objectives for today, 3 things that I'd like you to really take away. And I'll also say the Peds folks are going to be experts in this, because we talked a lot about this yesterday. So you'll see repetition from yesterday, but hopefully again, it's reinforcing what we talked about in a topic that many, I'm sure in this room, have never really dug into before. So we'll work to identify common cognitive deficits. And I really want our adult colleagues in the room to take this into your care and being aware of this even in a general nephrology clinic or transplant clinic, whatever it might be, in our kids as they transition and transfer to your adult programs. Explain how these deficits could really guide how we care for our patients, particularly in that transfer process or event to your adult programs. And summarize how these cognitive deficits could impact adherence to prescribed therapy, particularly within this population, I would say very vulnerable population, as they move into your adult clinics. So this is what we'll expect in Iowa in the next month. It's beautiful, but gets old about the end of February. I really also like to try to personalize who I am and why I'm here, because I think that lends a little bit of just fun to the story, right? So my story, I farm kid to the big city of Iowa City. There was a Starbucks there. So that's how you knew it was big, right? And so I grew up like this, with sheep, with cattle out on the farm all the time. And those, again, early events, I think, in my life were so formative as I moved to the University of Iowa. I have not gone far. I've been in Iowa since 1983. You do the math. And so came to Iowa City in 2002 and did my undergrad, med school, residency, fellowship. And I think that, rootedness of being in Iowa has directly facilitated and enabled the success with what I'm going to talk to you about today. This work that I will discuss is truly a labor of love, a passion project, but it's been 8+ years of growth to get to the point where we are. So the pathway here to get to where I'm at was directly influenced by at least 4 key figures in my life. As an undergrad, I started in psychology as a psychology major, and I literally fell into a research opportunity that truly did change my life. The first research experiences I ever had were in psychology in a children's judgment and decision-making lab. Again, I look back and I'm like, I cannot believe that happened. The grad student in this lab just left right before my senior year of undergrad. And Professor Levin, God love him, God bless him, just said, hey, here you go. This lab's yours to run. Full trust in a senior and undergrad. I cannot believe he did that as I look back, right? But those experiences in running a lab, doing IRBs, and being responsible, again, really enforced upon me. I liked research. And so then I came into medical school thinking, yeah, okay, I'm going to graduate in 4 years. I'll be, adult doc, or I'll be an ophthalmologist, whatever. Nephrology was not on my radar. And then I got into my first couple of years of medical school and realized I missed research. So I did a year-out research fellowship with Natalie Denberg, Professor Denberg, in neuroscience, looking at older adults and judgment and decision-making, and actually ran a full positron emission tomography study for a year that looked at decision-making and basically brain metabolism. I loved it, loved it. And then I had the opportunity through that to meet Dr. Napolis, who is my research career life mentor as well. She's a psychiatrist, and she, as I mentioned yesterday, is literally just a rock star. And her work is in juvenile and adult Huntington's disease, completely different than the kidney. She knew nothing about what the topics we were talking about when I first came into contact with PEG. But I stayed in touch with PEG throughout my year-out research fellowship and into residency. And then in med school and residency, I met Pat Brophy, who again was one of the most influential figures in my career. And I told Pat, I said, I really love nephrology. I think I want to be you, but I really am interested in the brain. And Pat's like, great, you can do it. Okay, again, this implicit trust that changed my career. So I say all of that because then why on earth would I be interested in the brain, right? I've had this historical interest, but then as a medical student, as a resident, and then as a faculty, we've all seen this. We've all seen these young adults. Again, that Raj was just talking about a moment ago, our teenage transplant recipients. And this is, again, a true little vignette that this young adult had been rocking it, very stable on medications, had some pill swallowing issues, so took liquid and took pills as well, like very small ones. But all of a sudden her TACRO was like undetectable, undetectable, undetectable. So we're trying to figure out why, trying to increase the dose, whatever we can do to get her therapeutic. And we had her back in clinic fairly quickly to kind of, hone in on what's happening. Well, it turns out mom had given her more support or more independence with her medications. And she'd been spending more time away from home, trying to, again, establish independence. And her TACRO was liquid, and she was just looks-alike in it. And just like, well, this looks about what I'm supposed to do. And again, major issues. And the big issue was that she didn't know how to measure the medication we're prescribing for her. So really going through, again, the process was critically important. And I think even as a parent, as a pediatrician, sometimes maybe we take that developmental trajectory or what we think a child should be doing and a young adult should be doing for granted a little bit. Kids are very good, young adults are very good at kind of concealing their deficits until you dig into them. And this is one of the slides that I think will directly reinforce exactly what was talked about on the last slide, is that brain development takes a while. And so with brain development, this is healthy control data, research-based control data from my mentor's lab that she collected as part of her HD, her Huntington's disease cohort. And this mirrors exactly what you would see from another large study called the ABCD study and other large neuroimaging cohorts that, yeah, probably the car insurance companies are right. 25 sounds great. My son, not drive until he's 25. So all of these things to say that we have developmental differences over time with our brains. And this is what we expect to happen for any of our patients, our healthy, patients that have come in for hypertension, or healthy patients that come in for, some history of AKI, whatever it might be. We expect this from them. And over time, we expect to see that age appropriately, the gray matter in your cortex, and I'm going to be very specific, cortex, should decrease with time. That synaptic elimination, the connections become stronger. And over time, as that synaptic elimination is occurring, the white matter within the brain, the highways, information highways, should become more robust. the information travels more efficiently, and then the connections are stronger. But then again, I showed this slide yesterday as well. This is the reality for many of our patients. So we've just asked them to do this, but they were born needing dialysis. Up to 60% in some epidemiologic studies of kids with chronic kidney disease have congenital anomalies of the kidney and urinary tract. So they're born with a kidney issue, and that kidney issue extends through their lifespan. And as we all know, transplant is not a cure for chronic kidney disease. At least yet, maybe someday with xenotransplantation, that's going to be different. We'll see. But that being said, this little guy right here in the middle, used with permission, was an 800-some gram baby that we had acute PD on when I was in fellowship. And this baby had twin transfusion syndrome, cortical necrosis, luckily recovered quite a bit of kidney function. But now this infant is 10 and has chronic kidney disease stage 3B. So that early life event set him up for the rest of his life of having some kidney dysfunction. Again, many of our kids have plumbing and piping issues, hydronephrosis in utero, VUR, et cetera. So it is a long-term problem. Now, again, I've just told you that brain development should happen in a particular way. And I've also just told you that our kids are faced with a chronic illness from birth many times, and then also trying to do normal developmental things. So then what do we know about cognition and pediatric kidney disease? This, I think, should also directly reinforce what Raj just talked about a few moments ago, that our kids are at risk for issues with memory, attention, and executive functioning. These are sort of the three biggies. And executive function, I really like to emphasize, like we talked about yesterday, it's like your brain's PDSA cycle: plan, do, study, act. You should be evaluating your decisions, and this is happening in your brain all the time through these complex networks. Now, any one of these three things can impact adherence to therapy, whether it be a fluid restriction, whether it be a sodium restriction, whether it be complex immune suppression management. And so these adherence to therapy requires that you remember to take your medication. It requires that you pay attention to the reminders on your phone. You don't just, silence it like we all do sometimes. And then the executive functioning component, right? Deciding whether it be consciously or subconsciously to put off medication taking until later. Anybody in the room that says they haven't done this is lying, right? We've all been here, but then take it to the next level and come into this thinking you've got a chronic illness and your body is trying to do normal development. How does that really impact this even further? And these cognitive deficits appear even before organ failure. There is a multi-center study called the CKD, Chronic Kidney Disease in Children cohort. The CKD study has very well described early cognitive deficits in pediatric CKD. This includes all comers, congenital anomalies kids, glomerular disease kids, other etiologies, and has gone back since 2006. So a very robust cohort of kids. And what you'll see, again, as Raj had highlighted on the slide previously on his talk, is that there are a wide variety of cognitive deficits that appear early. And they are also linked with clinical biomarkers, such as anemia, blood pressure, proteinuria, et cetera. And certainly some things like in early childhood, anemia, lower GFR, not surprisingly, probably associated with at-risk status for being behind on global development. Blood pressure, having more blood pressure variability, so less control, or just persistent elevated blood pressure is lower full-scale IQ, interestingly. This has been also seen in other non-CKD areas of work as well, in pediatric and in the adult data as well. One of the things that I'm going to point out here, just to kind of cue you in on, is this part right here, because one could very easily argue that having a congenital kidney anomaly could certainly set you up for other developmental issues, whether it be brain or whatever, because again, the development's happening, all sorts of signaling occurs multi-organ in utero. And so one group had looked at kids with chronic kidney disease and looked at actually copy number variants associated with the kidney disease status, and found that children that have a copy number variant potentially associated with their kidney disease had a higher risk for lower IQ. and also for lower executive functioning performance. So again, just kind of put a little in that, because we're going to come back to that topic in just a minute. So as a little like baby doctor and fellowship, I had started this interest in trying to understand kind of brain versus being, right? We in fellowship and residency, seeing these young adults struggling with adherence, with decision making, because ultimately one could argue at the end of the day, adherence is it's decision making, right? And so I was really interested in trying to say, like, I don't think these kids are just being, turds. I think there's something that's going on here. And so this is pediatrics. Welcome to pediatrics. And so I wanted to be able to get to the root at it, because I just had this really ucky feeling like there's something going on, and I don't like. We're honestly kind of casting blame sometimes on these young adults that, why don't you just take your medicine? Like, come on. And so that's where I started to dig into the literature, and really saw that most of our imaging, I don't know about the little overlap there, sorry. Most of our neuroimaging studies in CKD have been largely qualitative. So people had taken clinical scans and then basically qualitatively visually scored them. There was a significant lack of quantitative neuroimaging. And I'm going to come back to what quantitative neuroimaging is on the next couple slides. On the clinical scans, though, these qualitative studies, there was evidence really kind of going back, especially in the early 2000s, 1990s, of the cortical atrophy and concomitant ventriculomegaly in our kids with chronic kidney disease. But again, nothing concrete. Many of the studies that had tried to use this quantitative neuroimaging had done this in the absence of cognitive assessment. So you've got a structure without function, and it's hard to inform, again, a two-way street with that. And the other limitation is that pediatric chronic kidney disease, as was discussed earlier, is relatively rare, which is a great thing. But that makes it hard to do a really clean clinical study, observational study. Many of the papers that have been published had mild to moderate CKD, dialysis, transplant, all in the same bundle. They had lupus kids. They had kids with drug-induced CKD, nephrotoxic chronic exposure with congenital kids. So you've got all pieces of the spectrum, all ages and all diseases. And one could very easily argue that, again, a lupus patient is much different than a congenital anomalies patient. You've got glucocorticoid exposure and CNI exposure in our GN patients, and then the chronicity of the developmental kidney disease with a CACA patient. So that's where we came in. And the Brain Kid study is this kind of labor of love for the last 8+ years. Actually, technically more. 8's when I started as faculty, and we started this in fellowship. And the goal really at the outset of this work that I'm going to talk about in the next few slides ahead was to do this right, to really characterize a clean population, knowing that that was going to put me at risk for having a really small sample size. So we focused on kids with CACA, in part because then we could use age as a surrogate for disease duration. So that was kind of nice and clean. But again, the congenital anomalies kids have risk, as we talked about, like those copy number variants, the things that impact kidney disease could certainly impact brain development. So we're very clearly aware that that is a risk for confounding. In the K award, we looked at ages 6 to 16 and then expanded up to age 25 in our R01. These kids were mild to moderate CKD, no dialysis, no transplant history, no diagnosis of intellectual disability. I did not want to pull in kids that would skew the data. I really wanted to have a clean sample. And without history prematurity, many of our CKD patients due to CACA have some degree of prematurity. So anything less than 30 weeks was excluded. And no CNS anomalies. Because again, one could argue if you've got spina bifida, that's developmental, that's also at risk for different brain development. So really quickly, I eliminated probably about like 60% of our kids with CKD on all of these things. But with time, we've had a really outstanding opportunity to recruit quite a few kids on the data we'll talk about. The study visit, and this is important to know because this is, I think, also what sets our work apart, is that we have a metric ton of data. The kids come in, they get research labs. We have samples stored for future use. They have a comprehensive cognitive assessment, including intelligence, executive functioning, school services, developmental history, et cetera. And then this is one of our research MRI scans. This is not the pretty one that's got the like wrap on it that I showed the Peds team yesterday, but one of our dedicated research scanners. And the other cool thing about this is that these kids, even aged 6, can do this without sedation. They're able to be coached them through the scanner. They actually have a mock scanner we could use as well to practice. They hear the sounds. And out of all of the kids that we've scanned, controls and cases at this point, I've only had 3 not be able to do it. So pretty cool. The scanner though, the kids come in, and I want to again tell you this because this is important for understanding the next few slides and why quantitative neuroimaging is different. Our kids get a plethora of scan sequences in the hour they're in the scanner: structural, white matter, functional, like non-task based, but we're looking at the brain oxygenation, we're looking at blood flow in the brain, and other metabolic sequences, specifically acid-base sequences. And so the brain's in the scanner, we get all of the images back or the data back. The participant brain is then masked onto a standard, an atlas. So you have your cases, your controls in there, overlapped onto a standard age-appropriate atlas. And then that's able to be pushed through a computer pipeline that then says, okay, well, the standard, hippocampus volume is this is your kid's hippocampus volume. This is loosely speaking, but we can generate very quantitative numbers to say same or different than what you would expect for age. And you can do this for white matter, gray matter, for again, the fractional anisotropy, the white matter integrity, and so forth. And that's where this data becomes quite interesting, because instead of having a visual qualitative assessment, we have discrete data. Thus far, we have 37 kids in our R01 that have CKD. Actually, the next iteration of this data will be closer to 50, and then 87 controls with this data set. As you can see, I wanted to really emphasize that I would say this is a pretty well-matched study, which is also increases the strength of our findings. So as one might expect, kids that have chronic kidney disease due to congenital anomalies, there is a male predominance. So there is a male predominance of participants in the study. Age is a proxy for duration of disease, mean age about 12. And it's not surprisingly, the kids with CKD have lower GFR. Slight differences in socioeconomic status and maternal education and prematurity. And I want to point this out because all of these pieces, SES, maternal education, prematurity, are included in the models that we're going to talk to you about as far as the brain outcomes in the coming slides. So that's important to know that these are all accounted for. The kids with chronic kidney disease, I would say, were relatively well CKD. And I'll have to highlight this should be stage 4 CKD. So we have one kid that slipped in just a bit under the 30 lower threshold at the time of participation. So mean GFR of 71, relatively well dispersed between CKD stages 1 through 3. Duration of CKD is age proxy. They're not anemic, they're not acidotic, and they're mildly proteinuric. So again, very well kids. What I'm going to show you on the next couple slides really should set the stage to tell you that even though these are relatively well kids and many of them are in standard classroom settings, they are not neurocognitively matched with their peers. And so a grouped pegboard, I'll point out, is a measure of motor function. It's basically the speed at which you can put pegs on a little board. And then we looked at intelligence and achievement, and notably, again, our CKD patients underperform on everything, some of the domains quite significantly. And then we've also looked at executive functioning performance. These are 2 very well-established measures of executive functioning, the brief and the Dellis-Kaplan executive functioning system, the DCAFs. And there is really, really poor performance in many of these domains. And again, these are kids that are in a standard school setting many times. And we've got all of these cognitive differences. So I really want to hit home on this because I think it really points to the subtle yet potentially pervasive nature of executive dysfunction in our kids. And so as we started to look at the brain, I'm going to highlight just a couple things here. As we looked at the brain in my K23, and then as we moved into R01, the really striking findings from my K23 were the cerebellum. what the heck? The cerebellum. I had not even planned on looking at the cerebellum. I'm like, it's all up here. It's going to be frontal lobes if we're talking about executive functioning. Wrong. And this is where a mentor comes into play. Like my mentor was like, you can't just like exclude the cerebellum. It is part of the brain. So as we dug into it, this is really like one of those moments. And then we looked at the cerebellum and we said, well, okay, what about the kidney? So as we looked at cerebellum gray matter volume in these kids in the K23, we also found that with lower GFR, they had lower cerebellum gray matter volume. So as we moved then into the R01, we said, yeah, we've got these very interesting differences between cases and controls in a cross-sectional kind of approach. But remember early on, I showed you those curves. The brain changes with time, with age. So what is this just very cross-sectional global difference look like in the cerebellum if you include age? What are there other components of brain development that we're missing in this cross-sectional approach that age impacts? Again, duration of disease, age. So more recently with the R01, we've looked at these group differences, including an age interaction to really say, okay, yes, there are group differences, and this is really predicted again by group, but modified by age. And this slide is pretty bland. There's really not a lot of difference if you look at group differences with this age interaction. Again, all of these analyses are including maternal education, SES, prematurity, and none of those are drivers of any differences we see. But CKD patients really start to show that something is different when we look at the cerebellum. Again, the cerebellum. And so these three areas of the brain were the three areas of the brain that we actually found more recently in our larger group analyses, looking again with age, what you would expect for normal age-related neurodevelopment. It's not happening, interesting, in the cerebellum and the amygdala. And so what you can see as we move from left to right is the cerebellum gray matter. The red is the standard like control group, and this is as expected. It mirrors other larger data sets. There might be just a slight increase in cerebellum gray matter volume, and our CKD kids are just dropping off, which is really quite striking. And they're dropping off again in this transition period, this transfer period, which is a little bit like, holy moly, what are we going to do about this? Same thing with the cerebellum white matter. You should actually see those highways of information transfer strengthen in the cerebellum as outputs to the brain or to the cortex. And our CKD patients do not show strengthening white matter highways as they age. And interestingly, the thing that I didn't expect either, the amygdala has sort of a paradoxical increase in volume with age, whereas you see that the kiddos, the standard control kiddos, have a fairly flat amygdala volume change with age. So again, what does this mean? The cerebellum, really? Again, why? It's really quite interesting to me. It's one of those fun exercises and going back and saying, oh yeah, okay, cerebellum, we learned about this in neuroscience in med school, but what am I missing? And so again, this is where a great mentor comes into play, because Dr. Nepoulos is like, no, the cerebellum is executive functioning. Okay, this is a newsflash to me. So in particular, there's a really well-described syndrome called cerebellar cognitive affective syndrome, also called Schmahmann syndrome. And it's based on a very well-characterized cohort of young adults, children, adults that have posterior fossa tumors. And where the cerebellum is impacted is a specific area for this syndrome called the superior posterior lobe. Now, interestingly, again, the cerebellum develops in a way very similar to your cerebral cortex. There's the posterior to anterior development process, and also occurring in similar kind of juxtaposition as cortical gray matter maturation. So the superior posterior lobe is actually among one of the later areas to actually start to mature. And this superior posterior lobe of the cerebellum, these lesion studies with CCAS are highly associated with executive functioning deficits, spatial cognition, and language issues. And so we're like, okay, all right, well, sure, we know there's differences in the cerebellum, but is it this area? So as we went back and did segmentation analyses within the cerebellum, it is the superior posterior lobe of the cerebellum that's driving these gray matter differences, as you can see here on the left. Again, the healthy controls have pretty flat gray matter curves, but our CKD patients are definitely seeing lower superior posterior lobe volumes. The anterior lobe also starts to act like it's going to show some difference as well, but we did find some significance here. So the cerebellum is different. Okay, so what? Does it impact, again, cognition as we saw previously? And yes, it does. So if you look at these cerebellum areas in our CKD patients, cerebellum gray matter, lower cerebellum gray matter predicts worse performance on executive functioning measures on the brief. Lower cerebellum white matter also predicts worse emotional control or executive function performance, again, on the brief. And when we look at the amygdala as well, the higher amygdala volume, remember I showed you that that curve goes up, it's paradoxical, it should not go up like that. Higher amygdala volume predicts, again, worse executive functioning performance on the brief. So again, with the cerebellum, why the cerebellum? What's going on here? As we started to dig into analyses looking at connectivity, because we have to think of the brain again, it's so amazingly organized, only rivaled by the kidney. But with the brain, we've got all of these amazing networks. So if you take the cerebellum and you say, okay, how does it connect to the rest of the brain? There are these networks, white matter and gray matter connection networks. 5 major networks, like a salience network, default mode network, dorsal attention network, et cetera. These networks that then basically integrate continuously all of the information from our highways in the brain going back and forth. And we looked recently, and this is unpublished data, at the connectivity from the cerebellum, specifically the superior posterior lobe, and out through the brain through these networks. And so we looked at cerebellum connectivity through the 5 major connectivity networks. And in particular, the one that really stood out or stands out is that there is worse connectivity through this network called the dorsal attention network. And as is highlighted down here, the DAN and the dorsal attention network is crucial for facilitating basically a top-down approach to information understanding, that essentially it's acting as a mediator for these complex cognitive control tasks. Think of it, again, PDSA cycle, you've got to have control of what you're doing, and really highly valuable for decision-making and executive functioning. So again, just to recap this, the cerebellum connectivity through that network is less robust with lower GFR. We've got a lot of findings, but the why, like why is it injury? Is it development? Is it the disease process, again, an injury? What is it? What are we going to do with this data? So we've really started to look into recently neuro injury biomarkers in this population. And these neuro injury biomarkers in particular, one is called neurofilament light chain. It's kind of ironic because they've used this in a lot of NFL concussive studies and call it NFL. So this neuro injury biomarker is primarily a white matter injury biomarker, but also can be seen in gray matter injury as well. And we've looked at NFL and all of the kids that were in the study. These are all the same kids. And with age, the NFL level goes up. Also, again, duration of disease. And interestingly, the NFL level is highest amongst those with lower GFR and highest amongst those with the lower cerebellar gray matter, which is quite interesting. And that neuro injury is not isolated to just NFL. We see this in other markers such as tau and GFAP, glial fibrillary acidic protein. Okay, lots of kid stuff, but our kids grow up, as we talked about earlier, and our adult colleagues here are not taking care of the little guy in the corner. You're taking care of our older adults. And so I want to just touch a few moments on what you see from the brain in adult CKD and stage kidney disease. And this is a really catchy slide. I think it was from a review paper in 2021 entitled, "Is it removed during dialysis?" And the idea that there's been long-term interest in the brain in adult populations in particular, because of the recognition that some of your adults are on dialysis for long periods of time, and there are higher rates of dementia in adult populations, again, the so-called dialysis dementia, despite modified and improved therapies over time, removal of aluminum containing elements, better water improvement, et cetera. And your very robust adult data, which I am quite jealous of, does show that lower GFR is associated with higher prevalence of cognitive impairment. And that cognitive impairment in the general adult nephrology ESKD population is estimated to be 3 times more common, at least, than their otherwise non-ESKD adult counterparts. And similar to our kids, there's concerns in the adult literature for executive dysfunction and memory deficits. This is one of probably, I think, the best papers that's out here summarizing cognition in the adult ESKD population. This was done by Olone and colleagues, I think in 2021 or so, and was a systematic review and meta-analysis looking at adult data with a pretty robust number of patients. And here, this is really the important thing to look at, is they've got hemodialysis patients versus the general population, HD versus more mild moderate CKD, HD versus PD, and HD versus non-dialyzed advanced kidney disease, like kind of the less than 20 GFR. And HD is kind of not good. Although it's a great therapy, it is a life-saving therapy. There is an impact on the brain. I think it's fairly clear to see issues with cognition being worse in hemodialysis across all domains in the general population. Also largely trending worse for the CKD patients. PD may be worse in a couple of areas theoretically, but I would say the HD versus PD is potentially equivocal. And then the hemodialysis patients only do better than the non-dialyzed chronic kidney failure patients. So really pointing to the idea that our advanced chronic kidney disease is really, really hard on the adult brain too, potentially for some different reasons than in our pediatric patients. Again, in your adult patients, I was joking with our Peds colleagues yesterday. I thought about being mean and testing your cognition early in the morning and bringing the trails test and making y'all do it. But this is an example of one of the a test that was evaluated in this meta-analysis and systematic review. The trails test is getting at both motor and executive function, kind of attention. And so what you ask the patient to do is they go from 1 to 2, 2 to 3, 3 to 4, 4 to 5. And this is trails A. It's fairly straightforward, but it's timed. And the faster you go, the better, with less errors. If you have errors, you have to go back and then you lose time. Trails B is harder. And so you go 1 to A, 2 to B, 3 to C, et cetera. And so it's the alternation between letters and numbers. And again, what you can see here is that adult dialysis patients, both PD and hemodialysis, demonstrate extremely low performance on the trail making task. In your, again, adult literature, there's been some interesting data to look at the brain, and most of it has also been qualitative, but there's some quantitative imaging that we'll talk about coming up. One of the things that's very, very interesting, though, is that when you look at these brains qualitatively and quantitatively in your adult patients, the frontotemporal gray matter is most affected. And so we often think of, again, frontotemporal, frontoparietal as these dementia areas within the brain, like Lewy body dementias and so forth. So there are certainly areas of the adult brain that kind of mimic a true dementia volumetric loss. The other thing that's interesting too is you can see this is a standard T1, T2 scan here on A, and B is showing basically a susceptibility weighted imaging study where you can see that there are microbleeds here that if you look at a standard study, you don't see. So our patients potentially, again, could be at risk for other occult brain differences that aren't detected on a standard neuroimaging scan. And just, again, important to know that risk is present for your adult patients as well. One of the things that I think is really quite interesting, and we talked about this yesterday, it really just makes me take pause because I think this is an area where we can all educate our patients and help partner with our patients. And this is a really robust data set looking from overseas, looking at cerebral oxygenation using NIRS, like just the standard, like, brain NIRS equipment. And what they did is they assessed NIRS as cerebral hemodynamics or brain oxygenation using your NIRS probe among 95 HD patients during 2 consecutive treatments on Monday, Wednesday. And they defined cerebral ischemia as a greater than 15% drop from their baseline cerebral saturation at the time of start of therapy. And they found that cerebral ischemia was pretty common in HD treatments. So much so that up to almost 20% of the first weekly treatment in this adult population was spent in ischemic conditions. A little bit frightening. And these ischemic episodes probably are most likely, they think, attributable to volume status, where these ischemic episodes are more common after a long dialytic interval. It's, again, you think about you've got to get fluid off in a short period of time. You don't have a lot of options sometimes, especially in the adult units. You have a lot of volume, a lot of patients that are in and out of those units. And so certainly a challenge, because if they come in on Monday, they're heavy. We know there's myocardial stunning with more fluid removal. There's evidence for brain stunning too. This is also interesting data published earlier this year, and looked at some of the similar biomarkers that we've looked at in our kids, tau, NFL, another marker called UCHL1, and GFAP. And I'm going to really hone in on this top line here for the sake of time. And what we look at here and see is normal, mild cognitive impairment, non-CKD, non-ESKD, and hemodialysis. And in each of these three groups, the hemodialysis patients largely have higher neuroinjury biomarkers compared to even those with cognitive impairment, which is, again, quite striking. So then the big question is, well, transplant should fix it, right? Good question. And why is it an important question? This goes exactly back to what Raj talked about earlier. We really hope that transplant fixes this, because we're going to give these patients a lot of medications and we're going to ask them to manage it. Young adult, parents of young kids, adults, 50, 60, some-year-olds. This is an actual med list from one of our transplant patients when he was in the retransplant queue. Luckily, he's on much fewer medications now because he's doing great, but he was in college. And we had to do a short stint of dialysis for this patient because we had a little bit more accelerated kidney failure than we expected. And he was in college trying to manage his medications, trying to get to dialysis, all of these things. So then again, we know there are cognitive deficits. We're asking them to do a lot, including be independent, right? So just like Rush showed earlier, why on earth are we surprised by this? It should give you a little bit of like a, punch to the gut that we see this, and we see that at this point in time, ages kind of 18 to 25, as our patients are transitioning and transferring care and managing so much, that there's graft loss. And I think it specifically goes back to the points earlier that 18, probably not ready to go to the adult world yet. They still need developmental time. They still need teaching. They still need preparation, that transition readiness to avoid this. Now, there is data to suggest that maybe things do improve after transplant. Neuroinjury may resolve to some extent after transplant. This is adult data. Peds data, give me a couple years, we'll have it. But what we see in this study here, also again published earlier this year, looked at NFL, tau, GFAP, and amyloid beta, and they looked at non-CKD controls, pre-kidney transplant, post 12 weeks, and post a year. And this is striking, right? These numbers are significantly higher neuroinjury biomarkers than the non-CKD controls. But what's pretty cool, right, is that there's a pretty dramatic drop after transplant, even within 3 months. So maybe again, transplant does impact the brain in a positive way, which is what we hope. We hope to see these things for our patients. And I think anybody in the room that's doing Peds kidney transplant or young adult transplant would say that, yeah, when we see these patients come back to clinic after transplant, they're a new kid. They're able to, do more day-to-day life. But to what extent? Are those subtle yet pervasive executive functioning deficits resolved as well? Are they going to be able to manage that massive med list I showed you a minute ago? What we looked at, again, at Iowa, this was published a couple years ago by an outstanding post-bac who worked with me. We had implemented standard of care neurocognitive testing for our kids. And that includes, again, pre-transplant and then at least 1 year post-transplant when they're well. And so what we did is we went back and looked at all of the standard of care testing and said, okay, does cognition actually improve? Can we see a change over time? We used a mixed models approach so we could really include all of the data, which was a benefit to how we analyze this. So we could really look at potentially change in cognition relative to transplant. And one of the things that we found was that we may not see as much improvement as we think we do. And this really, if you take anything away from today, I want you to really think about, even though you're a young adult patients, your teenagers, your 25-year-olds seem like they're clicking along. What's under the hood? What's happening with these subtle but pervasive, potentially executive functioning issues? Again, things that you may not dig into unless you're really like what's happening with the TAC room, right? That sort of story. And so here what you see on the left side and then on the right side, this is the whole sample where we included patients with even just a pre or just a post and those with pre-post data. On the right side are only those that had, again, both points in time. And in particular, so things should ideally, if we're recovering our cognition, it should be closer to zero, overlapping the line, or to the right side of the zero. And our patients who received a kidney transplant actually had even lower scores at 1 year post-transplant on a particular domain called processing speed. Processing speed goes right back to what we talked about like 5-6 slides ago. It's part of that dorsal attention network. It's part of, again, integrating information, the top-down processing, things that you need for executive functioning. And again, in this sample, our processing speed in this group doesn't seem to improve if you take all comers or even just those with pre-post data. Is it modifiable? Can we fix it though, right? What is it about transplant that we can do or our care to help modify or improve brain outcomes? Again, I want to be very transparent. Our data set is, relatively limited. It's a modest size data set. But what we did do in this modest data set is we looked at dialysis duration, age at kidney disease diagnosis, etiology of kidney disease. This was all comers, CACet, GN, et cetera. And what we did find that was quite interesting is that being older at transplant was associated with those lower processing speed scores at a year post. And it kind of goes to the idea of crystallized versus fluid intelligence. Younger kids have more of that fluid intelligence. They actually may recover, they may catch up. And as we get older, unfortunately, we all know kind of got what you got. And so the older kids may just really have that crystallized intelligence effect where you may not be able to recoup chronic injury or recoup what had been potentially, again, lost from exposure to uremic toxins and other downstream effects of longstanding CKD. Now, I also want to be very transparent. I'm not saying that just because a kid has, CKD at age 2, that we need to just like rush to transplant. It has to be in a medically appropriate and safe way for the patient. But when we talk about this with our kids and our families, I think it's a good evidence that being prepared and really helping prepare them for transplant at the earliest possible and safest and appropriate time is important and can have a positive impact on them. Now, I'm going to give you just a little bit of a teaser as to what we're doing next, because I think we have pretty cool data. It's really clean, it's really comprehensive, but we're missing something like big time, the mechanism. I can describe this observation left and right, but why? And so this is where the idea of a lifelong learner comes into play, because I have been able to pivot recently and start to do this work in mice. Which is a big learning curve, but it's awesome. And I think, again, it points to the ability to sort of reinvent your career as you go along and follow the data, follow the story, and use that to drive where you go. So we are now working in a mouse model of chronic kidney disease it's an inducible renal hypoplasia model that we worked with Jack's Labs on. And these animals, again, have early life, that congenital CKD phenotype. We obviously have the just control Black 6 background mouse, but then we have animals that we're also doing a nephrotoxic exposure to, that's sort of an acquired model. And then what we're doing is with these animals, we're scanning them at 5, 10, and 15 weeks and looking at other biomarkers, obviously, of kidney dysfunction, BUN, et cetera, in the mice. and then doing quantitative neuroimaging with the mice. We're also doing neurohistology with the mice as well, and looking at the brain volumes from a neurohistological perspective, as well as like quantitative brain volumetrics. Mouse brains are really kind of hard to do because they're, especially when they're young, they're basically like a blob. And so it's definitely been, like I said, a learning curve. And we're really starting to come into some interesting data with the mouse work that we have thus far. One of the things in particular that you can see here, this is unpublished data at this point in time, is that if you look at the control mice versus the CKD mice, this is a Prussian blue stain. There's really not a lot of Prussian blue on here, but there's a lot of Prussian blue on here. So there's certainly potentially evidence of iron deposition and injury. Also differences in the neuronal cell count and cortical thickness. So our CKD mice actually have lower cortical thickness as a gross measure of their brain, but it's kind of loaded with cells, and the cells aren't normal. There's a lot of gliosis, a lot of astrocyte intrusion into the cortex, which is interesting. And then I have been very lucky to have an amazing postdoc that has facilitated much of this work. And actually her interest is in free radical and radiation biology, so oxidative stress. And we've also been looking at oxidative stress markers in here, in particular one that's 3-nitrotyrosine, again, a ROS marker. And the control up here, wherever the thing is, there. You can see part of the inner layer of the cerebellum here, and the CKD side has much more intense granular staining for 3NT. So there does appear to be some abnormal ROS generation within the brain in these mice. Again, why, or what are we going to do about it? That's the next question. And again, is it just a downstream marker? Probably of the kidney dysfunction, but is there something, especially knowing that there are free radical scavengers and other medications that are actually FDA approved, can we use to leverage to ameliorate some of these changes? So, as I wrap up, I want to just really summarize that these deficits, hopefully today you take this away in your care, is that these deficits must be accounted for in the transition and transfer of care. Stepwise integrated transition of care processes are necessary. They're so necessary, and they're so critical. And I would also encourage all of us to consider including neurocognitive evaluation. If you have that feeling you're not sure that it's clicking up here, just encourage the patients to go and say, like, I hope this helps improve your care. Working on teach back, making sure they understand exactly what you're saying, and considering also, as Raj had mentioned, inclusion of visual and written materials. The amount of times that I find that a parent can't read or is reading at below a 3rd grade level is striking and just sobering. So really, really try to take that into account as you work on your after visit summary or your medication list. And again, working with clinic coordinators, nurse coordinators, social workers to develop patient-friendly instructions and models really can't be overstated how important this is. And the opportunities for future research are robust. And what I really want to emphasize here as we close is that the young adult population is sort of this, it's like the missing generation, right? That 18 to 30-year-old age range is really not well characterized as far as what happens to the brain as we transition into the adult world, whether it be on dialysis, transplanted, or pre-ESKD, CKD. And there's so many opportunities within that to assess transition readiness, to use the cognitive data to hopefully tailor an approach for successful transition for our patients. And none of this can happen in isolation. We really have to have standardized approaches and multi-center collaboration to do this well. So with that, I am so thankful to have been here. I thank you for your attention today. Hopefully this spurs some thought in your clinics today, on the floors, wherever you're at, and just again, prompts potential positive changes in care for all of us. So thank you to my team in Iowa and other collaborators, and for the funding that I've had for this work. I'll take questions. Yeah. Thank you. Yeah. Mhm. Yeah, that's a great question. Thank you for that. It turns out Iowans, Midwesterners are very sort of like altruistic, right? And we pay them. So all of them do get paid. So we pay them $100, which is, you know, I mean, if you're 13, that's a big deal. Like my son's going to Target to get NHL 25 with that, right? So actually, it's fairly easy to get controls. Now, the challenge is that we are in a university like setting in Iowa City. So, you know, over time, obviously lessons learned with clinical research. When we first started recruiting and using like Qualtrics surveys, include, we didn't include a maternal or paternal education, like basically limit on it. And so we got all these really smart professors' kids, right? So initially, as we were looking at very early pilot data, we're like, we got to fix this because their IQs are 120 and things are skewed, right? So as we screen and we send out email blasts to the school systems, we send out email blasts to the university, then we were able to actually refine our control population to be a better match for our cases by saying like, okay, well, your mom has, you know, is a doctor, you're not eligible because of just, again, the socioeconomic influences probably on performance. So we sent out blasts, we sent out, you know, all over the community and we're able to recruit that way. So it's pretty cool. I mean, like I said, Midwesterners are pretty altruistic, which is great. Now the downside, which is what actually where Nationwide and Arkansas come into play to collaborative groups, Iowa is very homogenous. Like it's Iowa. And so our population is almost entirely Caucasian, which is also, again, a limitation because we are potentially missing even more difference based on socioeconomic disparity. And so we just submitted the renewal of this RO1, so everybody cross your fingers for it. But within the renewal, the 2 extra sites nationwide in Arkansas Children's are purposely picked to enhance the urban diversity, big city diversity in Columbus, Ohio, and then actually the much more, I would say, rural, non-white population in the South. So hopefully that also adds to what we're doing. Thank you, though. Yeah, back at the back. Yeah, great question. Great question. Let me know if you want to collaborate. But there's probably something that is definitely, I think, impacting both that is an underlying, you know, driver related to kidney developmental biology, brain developmental biology. Again, many of the same patterning programming genes that impact kidney development directly impact brain development, including cerebellar, right? So one might definitely say that if you've got problems with like a podocytopathy or other developmental kind of almost endothelial pieces of what we're doing, that the neurons are going to be impacted as well. So we have a lot to unpack with it. And I think hopefully with the mouse work, we'll start to see a little bit more true mechanism with it. But stay tuned on that. Give me like 5 or 10 years, maybe. It'll take a while to figure all of these things out, at least to get a footprint on it. And then other pediatric diseases that may share some overlap. Yes, there are. And it's interesting too, because I didn't touch on this, but our kids with pediatric chronic kidney disease, I don't know that this has been published, but I would say anecdotally probably have a little bit more risk than other, you know, general population kids for even mild autism spectrum. Definitely ADHD is up to 15% or more, I think, in some studies. Kids with CKD have ADHD, which is higher than the general population typically. A little bit more risk for seizures and things. And the autism and ADHD literature also does kind of hone in on the cerebellum as well. So what is it? Is it the kidney disease impacting these networks that then puts the kids more at risk for ADHD, et cetera? I'm not quite sure, but it definitely is interesting overlap. Yeah. Thank you. Yeah. Mm-hmm. Exactly. That's a great question. So one of the interests that Nationwide has and one of the great partnerships is that they have a really pretty robust, like, you know, GU clinic where they see a lot of solitary kidney kids actually in there. So that'll be one of the populations that we do try to include as well. Sort of again, the GFR greater than 100, doing great, no proteinuria, just that 1 in 1,000 solitary kidney sort of thing. So although there is data to suggest limited, but present data to suggest that the kids with even the solitary kidney do have a slightly higher risk of these mild executive function defect deficits as well. So, but yeah, great question. Yeah. Mhm. 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 Yeah, I'd have to look back on it. That's a great question as far as how many kids are excluded because of intellectual disability. Um, I would have to look on that one. I mean, a decent amount. It certainly happens more often than I would like to see. But again, it's being diagnosed great, but it certainly poses a risk there. So, all right. Yeah. Mhm. Mhm. Yeah, that is a great question. That's a, $1 million+ question right there. The idea of like, what can we do to circumvent this? Um, One of the greatest challenges, but yet again, benefits we have is the technology around us. We all have a phone. And many times our kids in the dialysis unit, right? They're on a screen the whole time. Even your young adults in the dialysis unit. And one could argue even a simple maneuver is just taking away the screen and having directed like interaction. Have somebody come and do a puzzle with the kid, whether it be a volunteer or child life, or if the nurses can sit in the room and do it. So just getting off the screen is a huge thing to actually then work on visual spatial skills, communication skills, problem solving skills, basic things that sound so basic, but it's really important. And so even within a dialysis unit in particular, I'm using this as an example with your older adults, with our young adults, with our kids, um, even just positive reinforcement to like do a crossword puzzle, do a Sudoku or whatever, Wordle, and finding ways to incentivize that. We all respond well to incentive. And if there are ways that, you can incentivize, hey, whoever wins this, Wordle this week gets a $5 gift card to the coffee shop or something, right? Things like that, that seem simple, but I think are actually very important. But also for kids, especially ensuring that they're in school. There is a really high rate of chronic absenteeism in many of these kids for a variety of reasons. I mean, even taking dialysis out of it. So making sure they have access to school supports and being in school um, and ensuring they have 504 IEPs, et cetera. So, yeah. Thank you. Mhm. Mhm. Yeah, actually, that question gives me goosebumps because, yeah, it is such an important part of what we do. And the risk for bias, social bias, is absolutely there in any clinical observational work. And it has to be an important factor and feature of how we systematically approach the data. And so one of the things actually that we're doing, what we propose to do in the next iteration of this study and the R01 renewal, is we're taking out all the paper pencil tests. And we're going to go to actually NIH Toolbox, which is, we think, less prone to those biases that you've mentioned. They're much more discreet neuroscientific tasks, and they take out more of the potentially socially granular components that could be influenced by socioeconomic status from a paper pencil test. So I think it's going to be a very different type of evaluation approach, but I do hope that it actually potentially levels even subtle differences in the playing field. So, yeah. Mm-hmm. Yeah. Yeah, great question about, again, exposure to medications. The nice thing about the CACUT kids is that in like the R01 and the K23, et cetera, they actually are relatively low exposed, I would say, right? An ACE inhibitor, maybe an erythropoietin stimulating agent, some bicarb. And so the exposures to, like, again, glucocorticoids or CNIs in the R01 data is not there, which is great. But there's excellent mouse data, which I'm sure many of you are aware of, right? That CNIs are not good on the hippocampus, and which memory and so forth. And glucocorticoids are also not good, and they're not good for white matter maturity and so forth. So that would certainly be another iteration of where we should go from here, is to maybe look at more of those exposed populations, again, like the GN populations, to see the impact of duration of exposure, sort of the cumulative dose exposure, timing in neurodevelopmental windows. I mean, that's a whole big bucket, but it's important because it is such a vulnerable population, and many of those patients, I think, are even more socioeconomically at risk. But even in the transplant work, so again, the next you're getting all of the exciting news flashes for where we're going for here. But the R01 renewal proposal is that we'll actually try to longitudinally follow these patients through the transplant progression. So instead of looking at mild to moderate CKD, the inclusion-exclusion criteria are really focused on CKD 3B and lower. And the goal of the first couple of years of the R01 renewal is that we're going to be recruiting patients basically at their transplant eval and getting them into the brain kid study, doing neuroimaging, neurocognition, biomarkers, et cetera, and then getting them back within the year after transplant, and then getting them back after that for another assessment. So then we would have to obviously like kind of map out those exposures, cumulative exposures, and so forth. So that's the goal, is to really do this in transplant. Other question? Yeah. Mhm. Yeah, that's a great question. So it's a specific domain that's generated from the Wechsler tests. And so they include that based on performance on validated processing speed assays or measures within the Wechsler. So again, well-defined, and it's like even things like spatial speed and memory tasks, as well as other like basically even basic kind of processing like arithmetic and so forth. How fast can you do these tasks? So it does rely again on some components of crystallized intelligence and that you know a fact to be able to do the task. But even then, other features of like processing speed could include word processing or letter fluency. So one common task is called the CAWA. Basically, it's a word availability task that taps into processing speed as well. And so you would be asked to name as many words as you can that begin with the letter F, right? Things like that. So you have to have the verbal output, the verbal fluency, but it also requires you to attend to what you've said before and to basically again, use those processing speed loops. So things like that are standard measures within the Wechsler scales. Great question. Good questions. Thank you for having me. It's been a pleasure to be here. I'm happy to stick around for a while to take other questions or discussion. Please feel free to reach out to me if you ever have questions about this or questions on how to potentially do this in your own clinics here. So thank you.